Good afternoon, everybody. It is a great honor to be speaking at LTSI Pune. I thank organizers for providing me this opportunity and organizing this video link as I couldn't travel due to some unforeseeable reasons. Coming to the topic, I have been asked to speak about intervention radiological management of delayed vascular complications after the liver transplant. So we can have three major categories of complications in the vascular division. Those are the portal vein related complications, hepatic artery related complications, and the outflow, that is the hepatic vein related complications. So we start with portal vein stenosis. It occurs in 2-3% of the patients in adults, but more common in pediatric LDLT cases. And technical factors like tight suture line or discrepancy in the size or use of graft are risk factors for the portal vein stenosis. In the treatment, in the IR options, the balloon angioplasty is the first and the foremost option. It is performed alone or with stents. And the access for the portal vein is, we all know, it can be direct hepatic access, or it can be transsplenic access, or it can be via transjugular access, same as it is in TIPS procedure. And the procedure begins with by measuring the pressure across the stenosis from the side of the mesenteric side of the portal vein and intrahepatic branches of the portal vein, and then measuring the gradient, how much gradient is across the stenosis. And if the gradient is above 5 mm Hg, it is generally considered hemodynamically significant. And balloon angioplasty is often the first choice. However, balloon angioplasty can be limited by its high incidence of elastic recoiling, restenosis, and as such sometimes we are compelled to use stents, which are usually have better chances of primary success and also have a long-term or at least the intermediate data shows that stents can have better patency rates. I show you with my first case. This is a 56 years old male, had CLD related to NASH and LRLT was done. 2 months later, he is undergoing PTPD followed by ERCP for biliary stricture. And 6 months later, he incidentally was detected to have portal vein stenosis. And these were the CT images. We can see this portal vein initially at the time of liver transplant. This was perfectly patent. But 6 months later, we see that there is severe stenosis at the hilum in the portal vein. Though this patient was incidentally detected, he was not having any symptoms, we decided to go for portal balloonplasty. So this is the angiogram and it shows clearly that there is a severe stenosis at the hilum, and we were able to balloon dilate it, and we were able to achieve a good portal diameter even without placing stent. So only angioplasty was done in this case. Second case, here there was portal stenosis which was again incidentally detected. Patient was asymptomatic 2 months after the transplant. Here we decided not to intervene initially, and 5 months later, the patient again turned up, but this time he has complete occlusion of portal vein because of the severe stenosis, and there is also some thrombosis. Also note that there is a large LR shunt which is filling up all the blood from the portomesenteric circulation. We were able to do angiography. These are the DSA images. We see that the intrahepatic portal vein branches are patent. The splenic vein is patent, but the main portal vein here, this is completely occluded and there is no flow. We were able to balloon dilate it, and after balloon dilatation we place a stent and excellent flow could be achieved. These are the follow-up images of the same patient. At 8 months, we see the intrahepatic branches as well as the main portal vein are patent. Sometimes we are come across this situation that we should do only balloon plasty or we should add stents. So how do we choose between the two? If we go to the literature, it is often we come across this thing that angioplasty alone has poorer long-term patency rates compared to stents, and stents can achieve up to 100% patency rates at 5 years. However, in our personal practice at Max CLBS, our policy is generally not to use stents in the first attempt unless the balloon plasty is unable to open the portal vein. In those cases, we use the stent. So we use stents if there is recurrence. Generally, we don't use them at the first instance because stents have their own drawbacks. There can be stenosis inside the stent, there can be thrombosis, fractures, and if there is a need for retransplant, then these stents can interfere with the anastomosis during the retransplant. And most importantly, in kids, there can be functional stenosis because the kids will grow, the stent will remain the same, and this creates a unique challenge. The second condition we will be discussing is persistent portosystemic shunts. This is an uncommon condition, uncommonly causes any symptoms, but it can happen. When persistent portosystemic shunts are large, they can cause hypoperfusion and graft failure, which can also cause portal vein thrombosis. Large shunts are generally ligated during the surgery. However, if they have not been done, endovascular embolization is an effective alternative to ligation. The various embolic agents used during the IR management are coils or vascular plugs. Again, the same patient which we stented earlier, there was a large shunt which we showed there, and we were able to do a Parto, which is basically a modification of BRTO, and this shunt was closed by the use of the plug. Another patient, she had portal vein thrombosis. When angiography was done, we found that there is a large shunt, coronary shunt. We were able to coil it. After coiling, the portal flow improved and the shunt was closed. Few years back, we also published our experience with these shunts and whether or not they always need to be ligated, and how and when we do the endovascular embolization for these shunts. We also published two interesting cases in the form of a case report. These patients had encephalopathy 15 and 11 years after the liver transplant, and they were initially thought to have Parkinsonism. They had Parkinsonism-like symptoms, but when we evaluated them in detail, we found that there are large shunts which are basically causing hepatic encephalopathy. After we embolized those shunts, their symptoms drastically improved. We come to the next vessel, most important, that is the hepatic artery. Hepatic artery complications, we have hepatic artery stenosis, hepatic artery thrombosis, pseudoaneurysms, and splenic steel syndrome. Stenosis is an uncommon complication, but if it occurs, it can lead to the graft dysfunction or biliary complications, and most cases are diagnosed with ultrasound as the resistive index becomes very low because there is less flow coming through the hepatic artery, so the organ shows vasodilatation and the resistance decreases. Options for these patients are again angioplasty and stent placement, and the literature shows us that angioplasty alone is inferior to the stent placement. However, like I said, stents have their own unique challenges, and in case of hepatic artery, there is an additional challenge that hepatic artery is usually thin, small, and sometimes having a tortuous course, which may make it difficult to land the stent in the correct position. Another complication is hepatic artery pseudoaneurysms. Usually they occur in the early post-transplant period, but they can occur in delayed post-transplant period also, especially patients who have persistent biliomas or infection. And the endovascular options for these patients include placing a stent graft or embolizing that super selective embolization of the branch. This is a 38 years female who was initially thought to have hepatic artery thrombosis on POD 30, but when we did DSA angiography, we started thrombolysis. We immediately found that there is an occult pseudoaneurysm which was thrombosed at that time, and it started bleeding. So we placed a stent graft here, and we were able to restore the hepatic artery blood flow as well as cover the pseudoaneurysm. Splenic steel syndrome or portal hypoperfusion. We know that it is basically non-occlusive hepatic artery hypoperfusion syndrome, where there is low blood flow in the hepatic artery and extra or hyperdynamic blood flow in the splenic artery. And diagnosis is usually difficult. It is confused sometimes with the hepatic artery thrombosis, but angiography clearly shows that there is a large artery, splenic artery, and thin, sluggish blood flow in the hepatic artery. For example, I show you this angiogram. You can see that there is excellent opacification of the splenic parenchyma, however, thin, feeble opacification in the hepatic artery. And when this splenic artery was coiled and embolized, we see that now the situation is reversed. We're getting excellent hepatic artery blood flow, and spleen is feeling delayed by the collateral vessels. So this is how it is treated, the splenic steel syndrome. The last thing we discuss about is hepatic vein complications, and in this we have the most important is the hepatic vein stenosis. It is again an uncommon complication but not so rare. Incidence can range from 5 to 11%, and it is again associated with some technical challenges or can be associated with the edema of the graft or kinking of the graft. The diagnosis is usually done by the Doppler ultrasound when we see that there is loss in phasicity of the blood flow in the hepatic vein, and cross-sectional imaging of course is always helpful, but the confirmation of the diagnosis comes from the pressure gradients, and if pressure gradient between the hepatic vein and right atrium is more than 3, it is usually significant, but some authors consider up to 5 or even up to 10 as significant. The goal of intervention in hepatic vein stenosis is to reduce that gradient. So balloon angioplasty is the first choice, and then we repeat the pressure gradients. If the pressure gradients come to the normal, we stop there. If they don't, then we might have to use stents. And stents have excellent patency rates, but again there are some challenges. Here is a patient who is 34 years female. Even on POD 43, she's making a lot of ascites. We have to drain it continuously, and you can see in these images there is ascites around the liver, around the spleen, and when we see this image in the coronal deformation, we see that there is an IHV which is showing severe stenosis at the ostia level. When we did angiography of the same patient, we were able to see that there is significant stenosis at the IHV ostia. We dilated it with a balloon angioplasty, and after angioplasty there was excellent flow, and the ascites disappeared within days. I thank you all. Thank you so much.